and welcome to ASC's webinar series. I am Jen Goss, ASC's Medical Education Specialist. Today's webinar is titled ASC Guidelines for Recommendations for Multimodality Assessment of Congenital Coronary Anomalies, a guide from the American Society of Echocardiography. Before we get started, I have just a few housekeeping items that I would like to go over with you. Since this is a live webinar, you have the opportunity to have your questions answered by the doctor. To ask a question, use the Q&A tab at the bottom of your screen. Feel free to ask a question at any point during the presentation. However, keep in mind that questions will be answered at the end of the presentation. We will do our best to ensure that all questions are answered. However, this may not be possible depending upon the number of questions presented. Once the webinar becomes enduring on May 4th, a Q&A transcript will be available and will be posted by the webinar. CME instructions on how to claim your CME today will be emailed to you after the presentation with a link to the evaluation and post-test. Please fill this out by May 3rd. If you should have any technical difficulties during this activity, you also want to use the Q&A tab and post that in that area. Let me introduce today's speaker. Dr. Peter Frommelt is a pediatric cardiologist in the Herma Heart Institute at Children's Hospital, Wisconsin, and professor of pediatrics for the Division of Pediatric Cardiology at the Medical College of Wisconsin in Milwaukee. He is the director of pediatric echocardiography at Children's Hospital, Wisconsin, and the director of the Pediatric Echocardiography Core Laboratory at the Medical College of Wisconsin. He has been an active member of ASC since 1991, serving on multiple committees and councils, including as past chair of the Pediatric and Congenital Heart Disease Steering Committee and member of the Board of Directors of ASC. Welcome, Dr. Frommelt.
Thank you very much, Liz. Thanks for that nice introduction. And I'd like to welcome everybody this afternoon to this webinar. My authors and I have no disclosures. I'd certainly like to acknowledge my co-authors on this guidelines and standards paper. Their important contributions were vital to crafting this manuscript. I'd also like to acknowledge the collaborating societies that partnered with us in this endeavor: the Society for Cardiovascular Angiography and Interventions, the Japanese Society of Echocardiography, and the Society for Cardiovascular Magnetic Resonance. Thank you to all of them. This guidelines and standard paper has been published in the Journal of the American Society of Echocardiography in March of this year. As far as learning objectives, at the completion of this webinar, you should expect to be able to recognize the different anatomic variations of coronary origin and course when congenital coronary anomalies are present. You should understand the benefits and limitations of different imaging techniques in diagnosing congenital coronary anomalies. And you should be able to describe appropriate imaging strategies for characterization of congenital coronary anomalies, both when the congenital anomaly is in isolation and when the coronary anomaly is associated with other forms of congenital heart disease. And I'll go through some specific examples as we progress through the webinar today. As an introduction, congenital coronary artery anomalies can place patients at risk for morbidity and mortality. And that's not just in older adults, but that's actually in children and young adults as well. Potentially lethal forms of congenital coronary artery anomalies are relatively common in the general population, occurring in almost 1% of people by some estimates. And so prospective identification using transthoracic echocardiography as a screening tool has become routine and very important. In fact, it's an absolutely well-established goal of the protocol in my lab. Multimodality image techniques have largely replaced cardiac catheterization as the primary tools for additional characterization of these anomalies, and we'll discuss those tools today as well. Starting with the specific tools that we use, we'll begin with echocardiography. We all know that transthoracic echocardiography is the ideal modality because it is risk-free, non-invasive, portable, and widely available. And so it should be an excellent technique when there are good transthoracic windows. The parasternal short axis view is usually the best view to identify coronary artery origins. And you can see that in this clip, identifying from a short axis view the left main, left anterior descending, and left circumflex coronary arteries. Color flow mapping documents direction and timing of flow, and I'll show you several examples why this is so important in identifying congenital coronary anomalies. In this case, in the normal left main coronary artery and LAD, you can see antegrade diastolic flow proceeding from the aortic root out into the coronary bed. I'll also talk about transesophageal imaging of coronary origin in their proximal course, because this also can be a complementary technique in imaging congenital coronary artery abnormalities. Cardiac CT can provide high-resolution imaging with 3D display of the coronary arteries and their relationship to extracardiac structures. And here's a beautiful example, a 3D reconstruction of a normal heart with normal coronary origins, left coronary artery arising from the left sinus of Valsalva, and then bifurcating into the left anterior descending coronary and its branches, and the left circumflex coronary artery. You can also see the right coronary coming off the anterior right sinus of Valsalva adjacent to the pulmonary outflow tract. Cardiac CT has rapid acquisition times with low radiation exposure, so it's really an excellent technique for imaging coronary arteries. However, optimizing techniques for imaging coronary artery lesions may require heart rate lowering medications, sedation and/or controlled ventilation in uncooperative patients, and ECG triggering sequence. So these studies should be supervised by experts in cardiac CT imaging of coronary artery origin and course. Cardiac MR has the advantage that it requires no radiation exposure and is not dependent on acoustic windows. Specialized techniques in display formatting allows 3D reconstructions, virtual angiography where you can literally walk into the mouth of the coronary to assess the osteal location and size and the course of the coronary, and you can assess myocardial perfusion and scar. This is important because many of the congenital coronary anomalies can be associated with ischemia and sudden cardiac death. So assessing how blood is flowing to the myocardium or whether there's been injury to the myocardium is frequently critical. Cardiac MR is limited by the need for sedation in many patients, particularly younger children, lower spatial and temporal resolution than what we can find with cardiac CT and sometimes with echocardiography, long acquisition times, and relative contraindications when a patient has metal implants. Nuclear perfusion imaging is frequently used to assess myocardial perfusion when a coronary anomaly places a patient at risk for ischemia. SPECT imaging, or single photon emission computerized tomography, is extensively utilized to evaluate cardiac perfusion and function at rest and during stress. And so you can imagine, again, as an important tool in assessing whether there is compromise to coronary flow when a congenital coronary anomaly is identified. There is a relatively high false positive rate, which results from motion artifact during image acquisition, which can limit this tool, particularly in young children. Finally, talking about coronary angiography, selective angiography is also particularly useful in situations where small discrete coronary occlusions or interruptions exist. Distal distribution of flow and patency is also best assessed by direct imaging with cardiac catheterization and selective angiography. Intravascular ultrasound can be placed during a cardiac catheterization, and that allows direct imaging of the coronary artery architecture and can quantify fractional flow reserve, the amount of flow passing through that coronary, which can be vital in determining, again, the patency of the coronary. This technique is reserved essentially for adults just because of the size of the catheters can obstruct the coronaries in smaller children. Radiation dosing with newer equipment is significantly reduced without a reduction in image quality. And so certainly coronary angiography remains an important part of our imaging techniques for congenital coronary artery abnormalities. I'm now going to switch gears and start to focus on specific lesions. We're going to start with congenital coronary anomalies that can occur in isolation. And so that means without other known heart disease. We'll start with anomalous aortic origin of the coronary artery from the opposite or wrong sinus using the acronym AAOCA. So AAOCA is a congenital anomaly whereby a coronary arises from the opposite or contralateral sinus of Valsalva with a variable course. And this cartoon illustration from the paper shows some of, but not all of the different variations in origin and course that occur with AAOCA. Although there are many variations as seen in this cartoon, the anomalous course tends to take one of 4 paths in general. The anomalous coronary can course posterior to the aorta. An example of this is in the cartoon in B, where the right coronary arises from the left sinus of Valsalva and then courses posterior to the aortic root. The coronary can course between the aorta and the pulmonary artery, what we call an interarterial course. And that's demonstrated in cartoon E, where the left coronary artery comes off the right sinus of Valsalva and then courses between the aorta and the pulmonary artery. The anomalous coronary can course within the myocardial sulcus below the right ventricular outflow tract, what's been described as an intermyocardial or interconal course. And that's depicted in cartoon F, where you can see that the left coronary artery again arises nominally from the right sinus of Valsalva and then courses within the myocardial sulcus below the right ventricular outflow tract. And finally, the coronary can course anterior to the pulmonary artery. And there's an example of that in cartoon I, where we can see just a portion of the left coronary artery, the left anterior descending coronary, arises anomalously from the right sinus of Valsalva and then runs in front of the pulmonary artery. Anomalous aortic origin of a coronary artery is relatively common and usually benign, but certain forms, particularly when a coronary artery courses between the great arteries within the anterior aortic wall, what we call an intramural interarterial coronary, are associated with sudden death. And so we'll focus on this form today, starting with echocardiography. Echocardiography can identify AAOCA with an interarterial course, and important markers include a more superior sinus origin of the anomalous coronary, an oblique course of the anomalous coronary from the opposite sinus, and that's represented nicely in this cartoon of an anomalous left coronary from the right sinus of Valsalva with an interarterial course. Normal coronaries rise perpendicular to their sinus of origin, where anomalous coronaries, when they are interarterial, tend to come off at an oblique or acute angle related to the sinus. And when they're intramural, and that's also depicted in this cartoon, the anomalous course of the coronary runs within the anterior aortic wall with, again, an acute angled origin that can be visualized by two-dimensional and color Doppler. And I'll show you an example. I'll show you several examples of intramural coronaries. So we'll start in this example, an intramural left coronary from the right sinus of Valsalva. So the same anatomy I just showed in the previous cartoon. The left coronary comes from the right sinus and runs within the anterior aortic wall. You have to be careful when you're imaging this, because the initial imaging can be misleading, because the anomalous coronary does exit the aortic root from the appropriate left sinus of Valsalva. So if you're not scanning up and through, you can miss the intramural portion. We're only catching the portion of the coronary as it exits the aortic wall here. With more superior scanning, again in this exact same patient, now we can begin to appreciate that intramural segment running within the anterior aortic wall and then exiting the aortic wall in its usual position from the left sinus of Valsalva. You can assume that this may be artifact. It's not clear. Is this really a true vessel, or is this just some artifact in the wall? And that's where color Doppler can be so important, because color Doppler helps to demonstrate that this is actually a vascular structure. Vascular structure. You can see, whoops. You can see linear diastolic flow within that anterior aortic wall. If it'll let me play. You can see that linear diastolic flow within that intramural segment, and it's coursing from the more anteriorly positioned right sinus towards the more posterior positioned left sinus. So it will have a blue color signal when it's an intramural left coronary from the right sinus of Valsalva. Looking at an analogous lesion, but now the intramural coronary is the right coronary from the left sinus of Valsalva, again depicted in this cartoon, where you can see a shorter, generally a shorter intramural segment from the left sinus. The right coronary then courses within the anterior aortic wall and exits from its usual position adjacent to the right sinus of Valsalva. And so this, again, clip shows that short intramural segment arising from the left sinus, because you can appreciate the commissure between the left and the right coronary cusps with that intramural segment. And then again, color Doppler flow imaging allows you to see that linear diastolic flow signal that really documents this is actually a coronary artery sitting within the anterior aortic wall. And the flow is red. It's coursing from the more posteriorly positioned left sinus of Valsalva to the more anteriorly positioned right sinus of Valsalva, telling you that this is an intramural right coronary from the left sinus of Valsalva. Additional imaging windows can help you identify an intramural anomalous aortic coronary, anomalous aortic origin of a coronary artery. The parasternal long axis view allows you to see that coronary running within the anterior aortic wall in cross section, like you're cutting through that coronary. So it'll appear as a discrete circle in front of the aortic root. And then in children with high quality subcostal imaging, or in anybody who has transgastric, transesophageal windows, you can sweep up from the aorta anteriorly, and you'll see the coronary coursing between the aorta and the pulmonary artery. So coming up, here's an intramural left running within the anterior aortic wall between the aorta and the pulmonary artery. You sweep from posterior to anterior. Transesophageal echocardiography can provide high-resolution complementary imaging in patients with the intramural form of AAOCA. As in this example, an anomalous left coronary again from the right sinus of Valsalva with an intramural course. So this is a transesophageal short axis view, again imaging from behind the heart through the left atrium. So the right cusp is anterior here. Here's the left cusp. Here's the commissure between the right and the left cusps. And you can see a normally arising right coronary in this position coming off appropriately from the right sinus of Valsalva. But immediately adjacent to that is the anomalously arising left coronary that then runs within the anterior aortic wall again to exit the aortic root from the left sinus of Valsalva. So you see that linear density, and once again, color Doppler is really very helpful in confirming that is in fact the coronary. You see again that linear diastolic color signal within the anterior aortic wall. Now that color signal is red, flow is coursing from the more anteriorly positioned right sinus to the more posterior positioned left sinus, so it's coursing towards the transducer when you're using transesophageal imaging. Complementary imaging techniques also include particularly cardiac CT and cardiac MR, and they can better define AAOCA anatomy, specifically the ostia, caliber, and distal branching of those anomalous vessels. Multiple techniques can also provide information about myocardial perfusion at rest and with stress, again, because one of the critical questions with this lesion is whether this coronary is able to adequately supply the myocardium, particularly since coronary events tend to occur in patients with AAOCA when they're active, particularly with vigorous exercise. So you can use stress echocardiography, you can use SPECT imaging, you can use cardiac MR. So to give you some examples of cardiac CT imaging, again, looking at an intramural left coronary artery from the right sinus, similar to the anatomy we've seen in the past. You can get beautiful two-dimensional echo-equivalent short-axis cuts through the aortic root that demonstrate first the normally arising right coronary from the anterior right-sided sinus. And here is that intramural segment of the left coronary also coming from the right sinus and coursing towards its exit near the left sinus of Valsalva. And the three-dimensional reconstruction, I think, is a beautiful example of this lesion. Right coronary coming off normally from the right sinus of Valsalva. And here's this long intramural course of the left coronary starting from the right sinus of Valsalva, coursing along the anterior aortic wall and then exiting the aortic root from the left coronary sinus. Similarly, this is an intramural right coronary from the left sinus, again using cardiac CT imaging. Again, an echo equivalent short axis view of the aortic root. You get a sense about the normal left coronary arising here, but a beautiful example again of that right coronary coming off at an oblique angle, the short intramural course, and then exiting the aortic root from the right sinus. In the 3D reconstructions, you can understand how valuable these are for clinicians. The left coronary coming off normally. Here's an example of that more superiorly oriented or positioned right coronary. It's coming off high from the aortic root near the sinotubular junction. But here's that short intramural course with oblique origin of that coronary, and then it becomes more normal in its distribution as it exits the aortic wall. For anomalous aortic origin of a coronary artery, our recommended imaging strategy is that transthoracic echocardiography can be an effective screening tool for suspected AAOCA, particularly in forms that are associated with myocardial ischemia. When an intra-arterial anomalous aortic origin of a coronary artery is identified, delineation of anomalous osteal origin and size and course should be confirmed with cardiac CT and/or cardiac MR. Resting and stress myocardial perfusion assessment may be used to help identify ischemia or to correlate with symptoms concerning for ischemia, but at present there is no imaging or perfusion algorithm that can consistently risk stratify patients with AAOCA in determining who is susceptible to sudden cardiac death. It remains a challenge for the cardiac community. Moving on to a second isolated congenital coronary anomaly, anomalous left coronary artery from the pulmonary artery, which goes by the acronym ALCAPA. ALCAPA is a rare congenital coronary anomaly where the left coronary arises from the pulmonary artery rather than from the aortic root. So this cartoon shows the normal anatomy, normal left coronary arising from the aortic root, with anomalous left coronary artery from the pulmonary artery. The entire left coronary system arises from the pulmonary artery. And this is a major problem because the pulmonary artery does not generate enough perfusion pressure to maintain antegrade flow into the left coronary bed. And so that coronary is only supplied by abnormal collateral connections from the right coronary that backfill the left coronary. ALCAPA is a treatable cause of myocardial ischemia and left ventricular dysfunction and needs to be ruled out at presentation. This is really important in anyone presenting with severe left ventricular dysfunction, particularly children, since the ischemia caused by this lesion can mimic a dilated cardiomyopathy. Many times a dilated cardiomyopathy is idiopathic, but it's when it's related to ALCAPA, we have a surgical solution that can dramatically alter the clinical course for that patient. Our surgeons now are very good at translocating that anomalous coronary from the pulmonary root and moving it back where it belongs into the left sinus valsalva from the aortic root, normalizing coronary perfusion pressure and flow, and thus, in many, many cases, normalizing left ventricular function. Echocardiography is the diagnostic imaging modality of choice for ALCAPA. Other imaging techniques may be necessary when it's not clear. And again, this is so important if a child or an adult has dilated cardiomyopathy and it's suspected. We need to identify this lesion because this lesion can be fixed. Characteristic echocardiographic hallmarks in this diagnosis include, not surprisingly, direct visualization of the origin of the left coronary from the pulmonary artery by two-dimensional imaging. You can see the coronary coming into the left or to the main pulmonary artery. Retrograde color flow Doppler from the left coronary into the pulmonary artery. Again, coronary perfusion flows from the right coronary through abnormal connections and backfills or retrograde fills the left coronary, and then that flow into the left coronary empties into the pulmonary artery. And I'll show you an example of that. There is extensive right coronary artery dilatation and tortuosity in many of these patients that you can see by two-dimensional imaging because it is the sole supply for all of the heart myocardium. Prominent intramyocardial color Doppler signals within the ventricular septum and LV myocardium can be identified due to dilated coronary collaterals from the right coronary to the left coronary artery, and I'll show you an example of that. Not surprisingly, with this ischemia, you can have significant left ventricular chamber dilatation and dysfunction. Again, it can mimic dilated cardiomyopathy. And there's also associated mitral valve muscle fibrosis, again related to the ischemia, with development of significant mitral regurgitation. So going through some of these characteristic features, we'll first start with direct visualization of the original left coronary from the pulmonary artery. So here's a really high quality short axis view, left coronary artery coursing near to, but not inserting into the aortic root, but actually then turning and terminating into the underside of the main pulmonary artery. This is the most challenging image to get because the coronary tends to course so close to the aortic root that you have to really be cautious in using just imaging alone to determine whether the coronary actually connects to the aorta or to the pulmonary artery. Retrograde color Doppler flow from the left coronary into the pulmonary artery is really an important hallmark of this lesion. You'll see flow coming from the distal myocardium into the LAD and then emptying into the left main coronary artery and then into the pulmonary artery. So retrograde or reverse flow in the left coronary is an important hallmark of ALCAPA. I mentioned before there's extensive right coronary artery dilatation and tortuosity by two-dimensional imaging, and here's an example of that, a significantly dilated right coronary because again, it is the sole source of myocardial perfusion. Prominent intramyocardial color Doppler signals within the ventricular septum and LV myocardium can be identified due to dilated right coronary collaterals. And again, here's these flow signals. They almost look like VSDs when you first see them, but they have a more linear characteristic and they tend to have a dominant diastolic flow pattern, not systolic like you'd expect with a VSD. So seeing these is an indirect marker of ALCAPA. And finally, significant left ventricular chamber dilatation and dysfunction. Again, this looks like a classic dilated cardiomyopathy. And look at the striking fibrosis of the mitral papillary muscle heads here that can result in significant mitral regurgitation. For ALCAPA, our recommended imaging strategy, transesophageal echocardiography should be the primary screening tool and is usually diagnostic in suspected ALCAPA in infants and children. Confirmation of the diagnosis using cardiac CT or cardiac MR should be reserved for cases where the anatomy is unclear. And this is a beautiful example in a patient where it wasn't clear, cardiac CT showing that abnormal connection of the left coronary to the pulmonary artery rather than the aortic root. After repair, cardiac CT or cardiac MR may be used when there are concerns about coronary artery anatomy as well. If after translocation, there's concerns that that coronary is not adequate in size or in caliber, there's been scarring related to the surgery. Our final isolated congenital coronary anomaly is a coronary artery fistula. coronary artery fistula is a congenital direct communication between a coronary artery and any cardiac chamber. The site of drainage for fistulas is usually a right heart structure, the right atrium, the right ventricle, or the coronary sinus. And although rare and frequently benign because they're small, fistulas can enlarge over time and lead to myocardial ischemia and or heart failure if they get big enough. Echocardiography may identify coronary fistulas with common markers including dilatation of the involved coronary artery with increased flow by color Doppler because there is a lot of runoff or steal into that dilated coronary. Turbulent continuous flow throughout the length of the involved coronary when draining into a low pressure chamber. And turbulent flow into that chamber at the exit point of the fistula by color Doppler because the fistula pressure is much higher than the low pressure cardiac chamber where it's emptying into, particularly when it's emptying into right heart structures. So just to show you an example of some of these hallmarks, here's a beautiful example of a very dilated and tortuous right coronary artery from a short axis image. You can see the tortuosity, the turn. This is actually part of the fistula as it's wrapping back around to empty back towards the right atrium. Look at the size of the right coronary compared to the normal size left coronary artery, significantly dilated. And this is a subcostal sweep through the aortic root where you can see the left coronary coming off quite dilated from the left sinus and then wrapping back around here. A little difficult to appreciate, and that's where color Doppler is so helpful because it can identify that turbulent continuous flow through the length of the coronary. Here's the origin of the coronary, then it curls back around. There's a long length of this coronary fistula that sits behind the aortic root. You can see that turbulent flow as it courses back and then empties into the right atrium. As far as coronary fistulas, our recommended imaging strategy is that transthoracic echocardiography should be the initial screening tool for a suspected fistula and is effective in serial monitoring of size and physiologic effects. When intervention for a significant fistula is planned, delineation of origin, course, and exit should be confirmed with cardiac catheterization, cardiac CT, or cardiac MRI. Hemodynamic information may be obtained by cardiac catheterization or cardiac MR when the need for closure is unclear. In coronary ectasia or dilatation of that proximal coronary segment following coronary artery fistula closure can persist and should be monitored for development of thrombus or ischemia. For the remainder of the webinar, we're going to focus on congenital coronary anomalies associated with other forms of congenital heart disease, starting with supravalvular aortic stenosis. So supravalvular aortic stenosis is a congenital localized or diffuse luminal narrowing of the ascending aorta at the sinotubular junction. You can appreciate that nicely here from this aortic angiogram. It is strongly associated with Williams syndrome and familial forms of the disease with genetic mutations that affect elastin formation. And it can be associated with potentially life-threatening coronary artery stenosis, particularly when the coronary arises near the supravalvular narrowing. So again, this coronary, left coronary coming off relatively high near the sinotubular junction adjacent to the supravalvular stenosis. Echocardiography can be limited in diagnosing coronary artery stenosis, but identification of an osteal location near the sinotubular ridge increases the risk of stenosis. So when the coronary arises closer to the sinotubular ridge or to the sinotubular junction where the ridge exists is a marker that is frequently associated with coronary artery stenosis. As you can see in this still of a transesophageal echocardiogram, looking longitudinally through the left ventricular outflow tract, you can see the ridge is actually hooding or covering the origin of the right coronary artery, and it led to significant right coronary artery ischemia. Alternative imaging techniques, cardiac CT, cardiac MR, and/or angiography can help identify these coronary artery stenosis more clearly, but use of deep sedation during these procedures can trigger an ischemic event because with that sedation, you can lower the perfusion pressure in an already stenotic coronary. Here's a beautiful CT imaging showing the supravalvular ridge here, compromise of the right coronary as it arises immediately adjacent to the ridge, also compromise the left coronary, not only from the ridge, but also from hooding of the left coronary cusp around the mouth of that coronary. So getting this kind of detailed imaging is critical in making decisions about surgical intervention. So for supravalvular aortic stenosis, our recommended imaging strategy, transthoracic echocardiography can be an effective screening tool for coronary artery anomalies with supravalvular AS, particularly in identification of anatomic subtypes associated with ischemia, particularly when that coronary arises near the sinotubular ridge. Cardiac CT is generally the preferred modality to document and confirm coronary osteal abnormalities, since it can be performed in many cases without deep sedation or anesthesia. And again, I've already talked about that is a risk in these patients, which can result in significant acute ischemic events. Another congenital cardiac lesion associated with coronary anomalies is transposition of the great arteries. Transposition of the great arteries is a congenital conotruncal malformation defined as concordance of the atrioventricular connections. In other words, the right atrium connects appropriately to the right ventricle, left atrium to the left ventricle, but discordance of the ventricular arterial connections. The right ventricle connects to the aorta, and the left ventricle connects to the pulmonary artery. So you have circulations that are in parallel rather than in series. Babies can only survive if they have either an atrial, ventricular, or ductal shunt to create mixing. The arterial switch operation is an effective surgical repair for transposition of the great arteries as it repositions the great arteries over the appropriate ventricle. It involves transfer of the aorta to the pulmonary root, so it now sits over the left ventricle, transfer of the pulmonary artery to the aortic root, so it now sits over the right ventricle, and then translocation or movement of the coronaries to the neo-aorta. You can see buttons being taken out of the native aortic root here. To maintain adequate perfusion pressure to the myocardium, the coronaries need to follow the aorta. There is significant variability in coronary artery anatomy and transposition. It's important to identify the anatomic pattern prior to the arterial switch operation because the surgeon needs to know what he has to do to move these coronaries. This series of cartoons shows the marked variation in the different patterns. They can have single right coronaries, they can have single left coronaries, but the coronary pattern that we worry about most is patterns where it is more difficult to do that translocation. Echocardiography can identify those patterns, particularly when there are intramural coronaries. An example here in this cartoon, an intramural left from the right coronary sinus and an intramural right from the left coronary sinus. And I'll show you some examples of that. So here's a infant with an intramural coronary pattern. This is the cartoon of this pattern, normal right coronary from the right-sided sinus, but the left coronary also comes from the right-sided sinus with a long intramural course within that posterior aortic wall. So from a short axis image, this is the aorta sitting anteriorly and the pulmonary artery sitting posteriorly. You can see this is normal position of the right coronary coming off the posterior and rightward aspect of the aortic root. But as we move the transducer just slightly medially, we now contract the length of the left coronary artery as it runs, again, in that posterior aortic wall between the great arteries. And you can imagine this is a much more challenging coronary transfer to accomplish with a significantly higher incidence of morbidity and mortality with the arterial switch. For postoperative imaging, ventricular dysfunction after the arterial switch operation should prompt alternative imaging techniques, cardiac CT, cardiac MR, and or angiography to assess coronary patency. It's very hard to assess that by echocardiography alone, particularly again when you're worried about myocardial ischemia that's creating this ventricular dysfunction. Here's a still frame again of the neo-aortic root after the arterial switch with a beautifully translocated right coronary, but a severely stenotic proximal left coronary after that transfer that resulted in severe left ventricular dysfunction after the surgery. For transposition of the great arteries, our recommended imaging strategy, Transthoracic echocardiography should be the primary imaging tool for delineation of coronary artery anatomy and the preoperative assessment of transposition of the great arteries. When an intramural coronary is suspected, as I demonstrated, clear delineation of this higher risk variant using cardiac CT may be warranted prior to arterial switch surgery. And postoperatively, cardiac CT, cardiac MR, and or cardiac catheterization should be performed when there is suspicion of coronary artery compromise, usually defined by ventricular dysfunction. Next, we'll talk about tetralogy of Fallot, another congenital cardiac anomaly associated with coronary anomalies. Tetralogy of Fallot is the most common form of cyanotic congenital heart disease. The anatomy is characterized by a large outlet ventricular septal defect with anterior malposition of the aortic root over both ventricles and severe subvalvular and valvular pulmonary stenosis that obstructs blood flow to the lungs so that right atrial, right ventricular blood is actually shunted across the VSD into the aortic circulation, creating desaturated blood, returning the aortic vascular bed with cyanosis. Surgical intervention is always required for this lesion to close the VSD and relieve the right ventricular outflow tract and pulmonary stenosis. So the VSD is closed so that all left ventricular blood empties only into the aorta, and then the right ventricular outflow tract is reconstructed, usually by placement of a transannular patch that splays open the right ventricular outflow tract and pulmonary artery. 5% of patients have major left coronary artery branches crossing the right ventricular outflow tract, which can impact surgical repair. So these coronary anomalies are generally a major left branch coming off the right coronary artery and crossing over anteriorly above the right ventricular outflow tract, LAD, dual LADs, or a single right coronary. You can imagine if there's an important branch coursing over the right ventricular outflow tract, that by placing this transannular patch, you can transect that coronary artery and cause significant coronary artery injury. Echocardiography can identify concerning coronary artery patterns in tetralogy of Fallot prior to repair. And here's a beautiful example, a still short axis image of the aortic root, normal origin of the right coronary artery as well, but a large left anterior descending coronary branch crossing the right ventricular outflow tract, just exactly what's been depicted in this cartoon. And then with a clip, we can see again, less pretty, but clearly seeing from this short axis view aortic root that there is an anomalous left coronary branch crossing the right ventricular outflow tract. And this would be in jeopardy if anything was done to open up this right ventricular outflow tract. Pulmonary valve replacement is commonly required after primary repair. Again, because the pulmonary valve in many cases is destroyed as part of the primary surgery. And so they need a pulmonary valve, competent pulmonary valve to control the severe pulmonary regurgitation. Evaluation of the coronary artery relationship to the right ventricular outflow tract should be obtained prior to any transcatheter or surgical pulmonary valve replacement because these coronaries can sit between the aorta and the conduit and can become compressed as you expand the conduit. You can see the coronary here cutting cross-section from a short axis view. You can imagine if its conduit is enlarged, it would be pushed or compressed against the aortic root. And even a better image of the danger that this left coronary artery sits in adjacent to this narrowed conduit. If you were to expand that conduit, again, that coronary could be compressed and flow to the left ventricular myocardium significantly compromised. Echo is usually not diagnostic in identifying coronaries at risk because of limited windows in usually these older patients when they come for pulmonary valve replacement with mediastinal scarring related to the prior surgery. So for tetralogy of Fallot, the recommended imaging strategy, transesophageal or transthoracic echocardiography should be the primary screening tool for delineation of coronary anatomy and the preoperative assessment of tetralogy of Fallot. After primary repair, delineation of coronary anatomy by cardiac CT, cardiac MR, and or angiography should be performed prior to pulmonary valve replacement. We'll next talk about truncus arteriosus, another congenital cardiac anomaly associated with coronary anomalies. Truncus arteriosus is an uncommon type of congenital heart disease in which a single arterial trunk arises from the heart, giving rise to the coronary arteries, the pulmonary arteries, and the systemic arteries, all from one common truncal valve, truncal artery, with both ventricles emptying into the truncal root through a large outlet ventricular septal defect. Infants undergo surgical repair for this lesion that baffles the left ventricle to the truncal root, creating a neo-aortic valve and outflow. And then there's placement of a right ventricular to pulmonary artery conduit to connect the right ventricle to the pulmonary arteries, since no pulmonary valve was present at birth. There is quite marked variation in location of the coronary origin and course. This is a bit of a complicated cartoon, but it gives us a sense about the variety of places that the coronaries can arise. So this depicts the truncal root in cross section. Open circles are right coronary artery origins, dark circles are left coronary artery origins, and the triangles are single coronaries. And you can see that they essentially can occur almost anywhere from this truncal root. And that can be a problem, and echocardiography can help identify problematic coronaries that could impact that initial surgical repair, particularly when the left coronary artery arises near the pulmonary artery origin. So it could get compromised when you excise the pulmonary arteries from the truncal root, and they usually come off from the more posterior and leftward aspect of the truncal artery, or when a coronary artery crosses anterior to the truncal root, again, so that when that coronary sits in the potential RV outflow tract, it can be transected when a right ventricular to pulmonary artery conduit is placed. Identical to Tetralogy of Fallot, for postoperative imaging, pulmonary valve replacement is commonly required after this primary repair. Infants outgrow their RV to PA conduit and need that replaced serially over time. And just exactly, in fact, these are the same images I showed for tetralogy. Coronaries can be jailed by expanding that conduit or replacing that conduit. So having a clear identification of the coronary artery relationship to the RV outflow tract should be obtained prior to transcatheter or surgical pulmonary valve replacement. For truncus, our recommended imaging strategy is that transthoracic echocardiography should be the primary screening tool for delineation of coronary anatomy and the preoperative assessment of truncus. After primary repair, just exactly like with tetralogy, delineation of coronary anatomy by cardiac CT, cardiac MR, and or angiography should be performed prior to pulmonary valve replacement. Our next lesion is pulmonary atresia with intact ventricular septum. Pulmonary atresia with intact ventricular septum is a congenital lesion in which there is no blood flow between the right ventricle and the pulmonary artery. The pulmonary outflow is atretic with varying degrees of tricuspid valve and right ventricular hypoplasia. Abnormal connections between the right ventricle and the coronary arteries are a common feature related to the high pressure in this hypoplastic right ventricle that has no effective egress. Identification of abnormal right ventricular to coronary artery connections can be made with echocardiography, as these apical four-chamber still frame shows. You can see a linear signal from the body of this hypoplastic right ventricle out towards the epicardium, and then scanning more anteriorly, you can follow this connection as it courses from the right ventricle into this dilated and tortuous left anterior descending coronary artery. A hypoplastic tricuspid valve, particularly when that tricuspid valve annulus z-score is less than -2.5, is a significant risk factor for the presence of abnormal right ventricular to coronary artery connections. And so screening should be very careful in that circumstance. Opening of the pulmonary valve will decompress the right ventricle and could lead to ischemia if there is what we call right ventricular dependent coronary artery connections. So confirmation of coronary artery anatomy is required prior to intervention and is best accomplished by angiography. This is an example of an angiogram into that hypoplastic right ventricle. And you can see the multiple right ventricular to coronary artery connections, both the right and the left coronary system, with areas of stenoses in those coronaries that would suggest that the right ventricle is important, or the coronaries are dependent on the right ventricle to maintain perfusion of those segments of the myocardium, so that opening the pulmonary valve could be detrimental to that patient. For pulmonary atresia with intact ventricular septum, a recommended imaging strategy is that transthoracic echocardiography can identify anatomic and physiologic features concerning for coronary anomalies, but it is usually inadequate as the sole tool to assess coronary artery anatomy in pulmonary atresia with intact septum. Coronary angiography should be performed prior to any interventions that would result in decompression of the right ventricle. I'm going to finish up with hypoplastic left heart syndrome. Hypoplastic left heart syndrome is a congenital defect with underdevelopment of the left ventricle and its associated structures with atresia or hypoplasia of the aortic and the mitral valves. Anomalous coronary artery origins or abnormal connections between the left ventricle and the coronary arteries are rare. In fact, abnormal left ventricular to coronary artery connections are almost exclusively seen in the hypoplastic left heart subtype with mitral stenosis and aortic atresia, analogous to what we just looked at with the pulmonary atresia intact septum. In other words, you have a patent mitral valve, but no egress for this hypertensive hypoplastic left ventricle, and so rarely left ventricular to coronary connections can be created, and these can be identified by echocardiography, similar to what we showed for the pulmonary atresia intact septum. For hypoplastic left heart syndrome, our recommended imaging strategy is that transthoracic echocardiography should be the primary screening tool for delineation of coronary anatomy in the preoperative assessment of hypoplastic left heart syndrome. Coronary angiography may be performed in the rare circumstance where abnormal left ventricular to coronary artery connections are suspected. That completes our webinar, and thank you very much for your attention with this, and I'm happy to review any questions that are generated during this webinar. So there is one question that was submitted, and the question is, what is the ideal aliasing velocity to demonstrate coronary blood flow by color Doppler? And that's a good question. I think if you noticed during the webinar, there was quite a bit of variation in what the Nyquist limit was set to image the coronary. I would say, again, as a general rule, what I mentioned before, having the Nyquist limit somewhere between 20 and 30 centimeters per second tends to work best. If you go lower than that, then you get so much smearing of the color around the tissue, it's hard to identify what is truly coronary flow. And if you go above that, you may be at a Nyquist limit that does not display the low velocity coronary flow patterns. The next question is the utility of coronary artery Doppler, and there has been some papers looking at coronary artery Doppler. I think it's a challenge, and I assume we're talking about spectral Doppler here. But the challenge is making sure that your alignment is appropriate, right? So you have quite a variation in your ability to align parallel to the spectral Doppler beam. And so a lot of the changes that you see in coronary artery velocities may be related to that alignment. And so it's hard to say what is a good flow velocity. In other words, what is a low flow velocity that suggests no obstruction compared to a velocity that suggests there is obstruction. The next question is, how often do you find anomalous aortic origin of a coronary artery in adults that were undetected previously? Yeah, you know, the imaging of the coronaries in adults, I think, is less reliable, but when you become very comfortable focusing on them, we have certainly seen that. Again, I would say, I don't think that our incidence is near 1%, but I would say that we see a couple every 1,000. So it still is an identifiable lesion. The risk stratification for those patients is a bit different. It seems like they're much less prone to die suddenly related to an anomalous aortic coronary. But there's still a lot of interest, a lot of information being collected about that lesion. Next question is, what is the difference between this sinusoid and a coronary fistula? So they sometimes are used interchangeably. A sinusoid is a ventricular myocardial connection to a coronary to the coronary artery circulation. A coronary fistula doesn't always empty into the ventricular myocardium. In fact, it more frequently empties into the right atrium or into the coronary sinus. So the sinusoid can be used when it is a coronary to ventricular myocardial connection. Can you describe pulse Doppler elevations in the right coronary off the left cusp? Again, I think people have had an interest in spectral Doppler assessment, particularly of the right coronary from the left sinus, because it's a lesion that's frequently well tolerated but has been described as resulting in sudden death. I can't give you any absolute information. I don't think anyone's come up with velocity profiles that tell you that anomalous right coronary is stenotic compared to non-stenotic. I don't think that that's been shown to be a reliable technique. The next question is about intramural versus interarterial echo features. It's great. It's probably another 5 minutes of the talk. Intramural is always interarterial. In other words, when it's intramural, it's running within the anterior aortic wall between the great arteries. So we can assume that an intramural coronary is an interarterial coronary, but there are forms of interarterial coronaries running between the great arteries that don't run within the wall. In fact, one form I briefly touched on, the interconal form, actually runs within that myocardial sulcus below the right ventricular outflow tract. A very different coronary anomaly probably also has a different risks stratification, in that the interconal appears to be much less dangerous for that patient than an intramural coronary. Next question is for a coronary CT in infants, or for example, when there is concern for an anomalous coronary in DTGA, what do you use for heart rate control to be able to obtain adequate imaging? That's a good question. I'm not a CT expert. They have used beta blockers in my institution. I think that's generally the answer for that question. Is the acute angulation for the coronary origin defined in the peristernal short axis? Is it defined as 30 degrees or less? That's a great question, and it actually really varies quite a bit. But I think if you look at normal coronary origins, that their angle of origin is always near 90 degrees, very commonly near 90 degrees. And so seeing a very oblique, much sharper origin of that coronary really, I think, is an important marker. And I don't think that you have to say that is it 30 or 40 or 60. It generally has quite an acute or very sharp angulated origin, particularly when it's intramural. Next question, there has been differing opinions at our institution regarding CT versus MRI in the confirmatory imaging for anomalous origin of a coronary from the inappropriate sinus. What is the best imaging strategy, or does it depend on the age and the scanner? Oh, that's really, again, a good question. I would say that they tend to provide complementary information. And so we've actually gone to a protocol where we actually do both, because we think that the anatomic information from the CT is important, but the physiologic information from the cardiac MR, particularly the ability to do myocardial perfusion and to screen for scar, is additive. And so we're actually doing both of those procedures, both preoperatively and then if they go and have surgical unroofing. Next question is, Do we need angiography in all cases of dilated cardiomyopathy to rule out coronary anomalies? And I would say no. Certainly at our institution, we rarely need to use angiography or any other imaging modality to identify ALCAPA. And that's really the predominant congenital coronary anomaly that causes dilated cardiomyopathy. And those markers that I talked about, identifying the abnormal origin from the PA, the retrograde flow is something by color Doppler we're very, very focused on, looking for septal collateral signals in a dilated right coronary. If you're really using all those tools, you should in most cases be able to identify ALCAPA by echocardiography